analgesic ladder, and in particular, the step 1 and 2. Okay, step 1 and 2 drugs. Also about the adjuvant drugs that we use and some drugs that we use for the management of neuropathic pain. Now, the WHO analgesic ladder was devised based on the recommendations of a group of international experts way back in 1986. So it is how many years now? Nearly 40 years, right? And so, in spite of so many years having gone by, it has stood the test of time. Even today, we are applying the ladder in our day-to-day practice. Okay. Not only for pain, but cancer pain, non-cancer pain, and even for acute pain. It has been translated into 22 languages, and it has really helped in the management of cancer worldwide, cancer pain. So what is it? It is a stepwise approach to treat cancer pain, depending on the severity of the pain. The criteria is severity of the pain. Now, prior to the analgesic ladder, that is prior to the 80s, people were dying with unnecessary pain. Firstly, because people were a little apprehensive about using opioids because there were a lot of drug regulations. And there was also stigma attached to prescribing and even taking opioids. So they felt that taking opioids is, you can become an addict. And even the relatives were scared to give the patients opioid. Doctors were scared to prescribe it. And the chemists were scared of stocking it also because of the severe stringent laws associated with opioids. But when the WHO introduced this ladder, it actually legitimized the use of opioids. So when the World Health Organization has promoted it, then that's a big help. And it has a lot of unnecessary misconceptions regarding the use of opioids were blown away. Okay. Now let me start with a case scenario. And I'll discuss this in the end also. So this is a 35-year-old father of two young children. He had squamous cell carcinoma of the right upper lobe. The pain was a deep-seated gnawing pain in the right shoulder with a burning and tingling sensation in the right arm. He was unable to sleep. The pain score was NRS 4 during the day and 6 at night. So we will see how we can manage this patient after going through this lecture. So before we start applying the ladder, we need to assess the pain. That is called a comprehensive assessment of pain. I think it might have been dealt with in the earlier class, introduction of pain. But just to remember, recapitulate, if you can remember the mnemonic PQRSSTU, then you will know a number of ways in which you can assess the pain. Out of that, the area of my interest is the severity of pain for the WHO analgesic ladder. So it is based on the NRS score. Okay. But also we need to know the type of pain. Is it a nociceptive pain or a neuropathic pain? Or is it a mixed pain, both nociceptive and neuropathic? So I think you may be familiar with what is nociceptive pain and what is neuropathic pain, but I have a slide in between. I can just show it to you later on. But this might have been dealt with you earlier also. So this ladder is a three-step ladder. The original ladder was a three-step ladder. The step 1 is for the mild pain, where the NRS score is less than 5. Okay. And there you give a non-opioid analgesic like non-steroidal anti-inflammatory drugs or paracetamol, with or without adjuvant, depending upon whether there is any other issue. Okay. Now, if it is not responding to step 1, then you move to step 2. Now, step 2 is when the NRS is around 5 to 7 and the pain is moderate. So here what you do is, in addition to the step 1 drugs, you're adding a weak opioid. I'll talk about it later on, what are the weak opioids. Now, if it is not responding to this also, then you move up the ladder to step 3, which is for severe pain, in which the score may be anywhere above 7, 8, 9, 10. Okay. Here what we do is, instead of the weak opioid, we add a strong opioid along with a non-opioid and with or without an adjunct. So that is the basics of the ladder. Now, with using this ladder, you can treat up to 71 to 76% of cancer pain satisfactorily. So that's a big thing. Let us see how this ladder can be used. So the salient feature of the ladder is all the drugs are given by mouth, that is orally. This is a standard route of administration of all these drugs, even the strong opioids. So that gives us a huge benefit. That means it can be used for domiciliary care. It can be used by the nurse who's visiting the patient, and patient need not be hospitalized to get any of these drugs. So very conveniently can be given for even terminal cancer patients who cannot even move from the home. So that is the one thing, is by mouth. Okay. The second thing you must remember is by the ladder. Now, what is that? Starting from step one, you move up the ladder. Okay. But sometimes, if the pain is very severe, you may have to start with step three drugs as an exception. But invariably, if you can start most of the time with step one, not responding, then you move to step two. So you go up the ladder. Okay. The third important characteristic is it is given by the clock. By the clock means the drug has to be given depending upon the duration of action of that particular drug. If it is morphine, it has to be given every 4 hours. If it is paracetamol, it has to be given every 6 hours. So we do not wait for the pain to come back to give the drug, but we go by the clock. So you have to explain that very clearly to the caregiver. You have to tell that you have to, in fact, make a chart for them. That's 6 o'clock, then 10 o'clock, then 2 o'clock. So if you make a chart for morphine, chart for paracetamol, they're able to follow it. So because of this, the peaks and valleys of pain don't happen, and there's a constant relief of pain in a range of less than 3 to 4, okay, or even better. Sometimes it can be even zero. But sometimes, despite that, you can have breakthrough pain. So that has to be treated appropriately. You'll have to explain how to treat the breakthrough. The, the basic thing is that pain should not occur and you should have a constant relief of pain throughout the 24 hours. Now, other thing is you have to individualize each regime to the patient. So the right dose is the one that relieves the pain of the patient. It can vary from patient to patient. For a young man, he may be getting about 120 milligrams of morphine, whereas a frail old man may be getting only 30 milligrams of morphine, but with both, they are getting the adequate pain. So it varies depending upon the type of pain, upon the severity of pain, and upon the patient, the patient habitus and the body weight of the patient or any other comorbidities the patient has. So you have to individualize it. There's no one standard dose can say that it works for all. One size does not fit all. Okay. The other thing about the WHO ladder is the use of adjuvant drugs. Now, these adjuvant drugs can be added at every step of the ladder for specific types of. I'll talk about it later on. And then you have to really pay attention to details. You should be very meticulous. You should account for the patient age, his body weight, the comorbidities. Side effects have to be monitored. You have to explain to them what are the side effects. When it happens, how do you handle it? So all these things have to be clearly explained to the patient. So what are the advantages of the WHO analgesic ladder? First of all, as you see, it is simple, easy to understand. It's a validated tool. That means it has been found to be effective by using this ladder properly. It's also cost effective because most of these drugs are relatively inexpensive drugs. It can be implemented across the world, even in the remote areas, and well suited for home care. Because, like I said, all these drugs are given orally. And it can be also given, like I said earlier, for acute pain as well as for chronic non-cancer, not just for cancer. Now, some modifications we can do for the ladder. For example, sometimes after step one, you may have to go to step three directly, or you may have to avoid step 1, step 2, and go directly to step 3. So all that depends upon the patient's pain. And sometimes you may have to add a fourth step to the ladder when you have to treat pain that is refractory even to morphine, right? So you may have to add a fourth step. So this is the fourth step of the ladder. It was devised somewhere in 2000, and it is for those 10 to 15% of patients who have not responded to the strong opioids. Of course, sometimes it can be given even before also, because sometimes you may have to give an epidural before or a nerve block before, but usually it's given when they are not responding to the step 3 drugs. So what are these step 4 modalities that we use? They could be a nerve block, it could be epidural injections, it could be a patient-controlled analgesia pump by giving, either you can give it epidurally or intravenously. You can give a neurolytic block like a stellate ganglion block or a celiac plexus block or a lumbar sympathetic block, whatever. Or you can even use intrathecal opioids and even spinal cord stimulators. So these are all, and I will be going a little more detail when we do the session on difficult pain. Okay, so then I think we'll go a little more in detail. Now coming to the step 1 drugs. So what are the step 1 drugs? These are paracetamol and non-steroidal anti-inflammatory drugs. Now, paracetamol is also called acetaminophen in the US. Now, it acts centrally. It inhibits the enzyme cyclooxygenase or COX in the central nervous system. It has no effect on the peripheral COX. And because of that, the side effects are less. I'll talk about it in the subsequent slides. It has basically an antipyretic and analgesic action, and it doesn't have any significant anti-inflammatory action. What are the doses? You all are all familiar with it. Just to recapitulate, you can give it in a dose of 12 to 15 mg per kg every 6 hours, up to 3 to 4 grams a day, but it should not exceed 4 grams. And a single dose should not exceed 1 gram. The normal dose that we give is around 650 mg every 6 hours. We have also 1 gram sustained release tablet, out of which 250 is immediately released and 750 is released over the next 12 to 24 hours. So the sustained release tablets are also available at us. Can be given as an infusion, 1 gram every 6 hourly, but of course this has to be given in a hospital setting. Can also be given rectally when the oral is not feasible. Very safe for pediatric use in a dose of 15 ml per kg 6 hourly. Toxicity occurs in doses of more than 90 milligram per kg per day. Now, a word about numbers needed to treat. Now, what is the NNT of paracetamol? Now, what is numbers needed to treat? This is the number of patients who receive the drug for one to have 50% relief of pain over the next 6 hours compared to a control. So if the NNT is lower, the drug is said to be more efficacious. That means if you're giving for 5 patients and only 1 gets relief, the NNT is 5. But if you're giving it to 2 patients and 1 gets relief, the NNT is 2. So the lower the number, the more efficacious the drug is. Now for paracetamol, the NNT is 5. That means for every 5 patients, 1 gets very good pain. So it is not as efficacious or analgesic as the non-steroidal anti-inflammatory drugs like ibuprofen or diclofenac. They have a smaller end. What are the advantages and the drawbacks of paracetamol? The advantages are it has a very good safety profile. The undesirable effects are relatively uncommon. It has no adverse effect on the gastric mucosa, well tolerated by patients with peptic ulcer, no adverse renal effects, no effects on platelet function. 2/3 of the patients who are hypersensitive, they tolerate paracetamol very well. Okay. And it also does not affect the plasma uric acid levels. But the drawbacks are it has to be given every 6 hours. It has no anti-inflammatory action. It has a potential for hepatotoxicity if it is given in high doses of more than 4 grams in the presence of liver dysfunction, when the patients are chronic alcoholics. If the body weight is less than 50, then you must restrict the dose to 2 grams per day. And even in liver disease, you can give 2 to 3 grams per day. It's not absolutely contraindicated in liver disease. So in cancer pain, it's the mainstay of the WHO analgesic ladder. Why? Because of its safety profile, because it has an opioid sparing effect. That is, when you're giving paracetamol, the dose of opioid is lower, and it is used at every step of the ladder. Step 1, it's given with NSAIDs, where the NNT will improve to 2. In step 2, it can be given in combination with tramadol and tapentadol. And in step 3, it's given as a combination with opioid. So it can be given at every step of the ladder. Now, coming to the next drug that we use as a step 1 drug, which is a non-steroidal anti-inflammatory. Now, these, unlike paracetamol, act by inhibiting the peripheral cyclooxygenase. This is a very important enzyme in the arachidonic acid cascade, which ultimately produces the tissue inflammatory prostaglandins, which are responsible for mediating pain and inflammation. So how do they mediate it? By peripheral sensitization and amplifying the pain. So this NSAIDs is primarily effective in nociceptive pain, because in nociceptive pain, you have tissue injury. And that is where all these enzymes are released. Okay, prostaglandins are released. It's not as effective for neuropathy. Now, if you look at this diagram, you see here, if the tissue damage occurs, there's a release of all these tissue byproducts and inflammatory mediators, which includes prostaglandins. So they all form here, they're all released, and they form a kind of a soup, inflammatory soup around the peripheral nerve ending. See, this is the first order neuron, and this is the nociceptor, which in case of pain, it is the nerve ending, free nerve endings, right? So these anti-inflammatory drugs are acting at this level, where all these mediators are released. So it also depends on the extent of tissue damage. If there's a crush injury or a major trauma, there is more tissue damage, more release of these inflammatory prostaglandins. So this is called peripheral sensitization. Okay. And that is how the pain is going through the first order neuron into the dorsal horn of the spinal cord. This is the pain pathway. So if you look at the cyclooxygenase enzyme, when tissue injury occurs, phospholipids are released. Then you have the arachidonic acid pathway that starts, which releases the prostaglandins. And these enzymes, the COX-2, is the one that releases the prostaglandins. So this happens only when the injury happens. Otherwise, it is not released. But normally, there's an enzyme called COX-2, which is the constitutive or the housekeeping enzyme. And that is an enzyme that is present in all normal tissues, which is responsible for the physiological responses, like protecting the stomach, the kidney, and facilitating platelet aggregation. Okay. Whereas COX-2 is released only by inflammation or tissue injury. Okay. So this is COX-1 and COX-2. Please remember that. So the effect of this is undesirable, but the effect of this is desirable because it is maintaining the homeostatic function. So if you look at the anti-inflammatory NSAIDs, there are two types of NSAIDs. One is the non-selective ones, which are inhibiting both COX-1 and COX-2. The selective COX-2 is interfering only with COX-2. That means the beneficial effect of COX-1 is preserved. So if you look at the non-selective COX inhibitor, that is inhibiting both COX-1 and COX-2, they include the aspirin, ibuprofen, naproxen, ketoprofen, diclofenac, piroxicam, ketorolac, indomethacin. These are all non-selective COX inhibitors. So like I said, because they inhibit COX-1, it produces the adverse effects like the GI side effects, the hypersensitivity, the adverse renal effects, etc. But because it is inhibiting COX-2, it is an anti-inflammatory, analgesic, and antipyretic effect because it is acting against these prostaglandins and the inflammatory mediators. So the non-selective NSAIDs, it's a double-edged sword. It has both adverse and beneficial effects. So the examples are one, ibuprofen, it is given orally. The NNT is only 2. That means it's a very good analgesic. And naproxen, it's also given one of the non-selective NSAIDs. Its NNT is also very good, around 2.7. You remember paracetamol NNT was 5, whereas this has got a better analgesic. So what are the side effects of non-selective NSAIDs? Because of the COX-1 inhibition, right? That is the renal effects. And this is more if dehydration is present. So whenever we give NSAIDs, we must tell the patients to drink adequate water. I write it down on the prescription. Please drink adequate water. Because in the presence of dehydration, the chances of acute and chronic renal failure happens. Then gastrointestinal, like bleeding and ulceration, and hypersensitivity reactions like respiratory, like bronchospasm. It can be skin allergies, or it can be more generalized, even angioedema can happen. Now, the selective COX-2 inhibitors. They are not inhibiting COX-1, they are only inhibiting COX-2, so the beneficial effects are retained. They include etoricoxib, known as Mucoxia or Etoshine. It's given a dose of 60, 90, or 120 mg in a single dose. It's only once a day dose. Or you can give celecoxib, which in a dose of 100 to 200 mg twice daily, or diclofenac, although it is supposed to be a non-selective, but functionally it is more selective because its GI side effects are less, but the renal effects are still there. Its NNT is very good. It's 2. Okay, so it's a good analgesic. Now the question is, are selective COX-2 inhibitors safe as compared to the non-selective COX inhibitors? Where the GIT is concerned, it is definitely safer, but where the renal damage, it is comparable to the non-selective NSAIDs. But the other problem is that the selective NSAIDs are more prothrombotic. There are more likelihood of myocardial infarction and stroke, particularly if there's a history of atherosclerosis or a history of a stroke or a history of MI, then you should not give a selective COX inhibitor. Okay. And in fact, one of these drugs like rofecoxib was taken off the market in the US because of the incidence of thrombotic phenomena. In such cases, if you want to give an NSAIDs, then ibuprofen and naproxen would be better in patients who are at risk of thrombotic events. So NSAIDs can be given other than the oral route, like you can give topical NSAIDs because it produces an analgesic effect with less risk of systemic absorption and toxicity. It's available as gels, creams, and sprays. And some of the ones that we have commonly used are ibuprofen, diclofenac, piroxicam, and ketoprofen. Can also be given transdermal patches. You have diclofenac patches of 200 mg available as new patch or gel. So the risk factors for NSAIDs toxicity I've just summed up here. For GI toxicity, particularly GI bleeds, you should be very careful, avoid it. Renal toxicity, particularly in the presence of dehydration or nephrotoxic drugs are being used, or if the creatinine clearance is low, elderly people avoid NSAIDs. But if there are risk of stroke and MI, all these are the risk factors, then avoid the COX-2 drugs. Now we come on to the step 2 drugs. Now, these drugs, unlike the strong opioids, are the weak opioids and they are not controlled. Okay. That means they are not under the strict, the rules as compared to the strong opioids. So they are given for pain of moderate intensity, which are not controlled by step 1 drugs. The examples that are commonly I'll be discussing are tramadol and tapentadol. Now coming to tramadol, it is a centrally acting synthetic weak opioid. Now, because it is a weak opioid, there is a less chances for respiratory depression and addiction potential as compared to morphine. But it is also has a non-opioid method of action, and that is it blocks the presynaptic reuptake of serotonin and norepinephrine, which is in the descending inhibitory pathway of pain. So it is also good for neuropathic pain, because neuropathic pain is mediated by serotonin and norepinephrine, by the decreased level of serotonin and norepinephrine. So when the reuptake is inhibited, the analgesia occurs. That is how the neuropathic pain happens. Now, tramadol is a prodrug. That means it's converted to an active metabolite for its analgesic effect. So the combination of tramadol and paracetamol is widely used as a step 2. The advantage is high oral bioavailability. The plasma half-life is 6 hours. The oral dose is very potent. It's 1/10 as potent as morphine. So if you give 400 mg tramadol, it is equivalent to 40 mg of morphine. You divide 400 by 10 and you will get the equianalgesic dose of morphine. The dose is 50 to 100 mg every 4 to 6 hours, up to a maximum of 400 mg. Sustained release tablets are also available, which can be given twice. It has some side effects. Many people complain of dry mouth, nausea, vomiting, constipation, dizziness, and even sedation. There is a risk of seizures also, but that is when the total dose is more than 400, when you give it as a rapid IV injection or along with drugs that lower the seizure threshold like TCA and SSRI. When you're giving tramadol IV, we always say, please give it over 20 minutes as an infusion. Now, the other weak opioid is tapentadol. This is a newer step 2. It is supposed to be a weak opioid, but opioid binding studies are showing that it is actually quite a strong opioid. If you look at this, 75 mg of tapentadol orally is equal to 30 milligram of morphine per also oral. Whereas in tramadol, it is 400 tramadol with 40 morphine. So it is more potent than tramadol. Action is similar to tramadol. It is a mu receptor agonist and it also blocks the inhibitory pain pathway, similar to tramadol. It is not a prodrug and it does not have active metabolites. The dose is also similar to tramadol, 50 to 150 mg every 8 hours. Sustained release formulation are available. Do not exceed 600 mg. The side effect profile is slightly better as compared to tramadol. Okay. But you should avoid it in renal and hepatic dysfunction. So if you want to combine analgesic drugs of step 1 and step 2, just remember the following dictum. One is you do not combine COX-1 and COX-2 inhibitors. That means you do not give a non-selective and a selective drug together. Second, you do not combine a weak opioid with a strong opioid. So if you're giving morphine, there's no need to give tramadol. The other thing is the combinations that are favorable are paracetamol NSAIDs with morphine, or paracetamol with NSAIDs, or paracetamol with tramadol. These are the favorable combinations. Now let us switch gears and move on to neuropathic pain. Why do we need to know about the neuropathic pain? Because that is when we are using adjuvant drugs, which are there in the analgesic bag. So 40% of cancer patients have got neuropathic pain. They also have bone pain. They can have bowel obstruction pain. They can have pain due to muscle spasm, and they can have other symptoms. So that is why it is important that the adjuvant drugs be also managed. So adjuvant drugs have analgesic properties, but the primary indication is not for pain. So they are called co-analgesics because they are co-administered with other analgesics of the WHO manual. A simple classification of adjuvant drugs based on clinical symptoms are: one is there's a multi-purpose drugs which can be used for a variety of conditions. Then there are drugs for neuropathic pain, drugs for analgesic adjuvants for bone pain, adjuvants for bowel obstruction pain, adjuvants for muscle skeletal pain, and other symptoms also adjuvants can be used. So I wanted to tell about what is nociceptive and neuropathic, the simple diagrammatic representation of the pain pathway. See, this is a peripheral nerve ending, and this is where tissue injury is happening because of the cancer or any problem. So the nociceptive pain is this pain that is perceived at the periphery or at the tissue. Anything beyond this, that is a first order neuron or the dorsal horn, the spinal cord, and the ascending pathway and the brain, they all come under neuropathic pain. So neuropathic pain is caused by a disease or lesion in the peripheral or in the central nervous system. Okay, this is a definition by the Indian Association of Study of Pain in 2008. But many times, cancer pain can be mixed, both nociceptive and neuropathic. Now, why does neuropathic pain occur in cancer? One is because the cancer itself can cause direct invasion or compression of the nerve, which can be either a mononeuropathy or a plexopathy. The treatment of cancer itself can cause neuropathic pain. For example, we have the chemotherapy-induced peripheral neuropathy because the chemotherapy drugs is also destroying the peripheral nerves along with the cancer. Then you have radiation-induced neuropathy. You have neuropathy because during surgical excision, if a damage to the nerve has happened, it can cause neuropathy. But neuropathy can even persist for months or years in cancer survivors because of permanent damage to the nerves. Okay, so that is how we should remember neuropathy. So the first line of treatment of neuropathy is the anticonvulsants. Now, why are anticonvulsants used for neuropathic pain? Because both have a shared pathophysiology. In both, there is neuronal hyperexcitability, and the anticonvulsants are dampening the neuronal excitation. And the most commonly used anticonvulsants, I will talk about it when it's. How do they act? The gabapentinoids. Now, these gabapentinoids like pregabalin or gabapentin are binding to the voltage-gated calcium channels and preventing the influx of calcium into the presynaptic neuron. As a result, there is less decrease of the excitatory neurotransmitters like aspartate, glutamate, and all this. And because there's less release, the postsynaptic membrane is not getting activated. But it also acts on the sodium channels. Besides the calcium channels, it's also acting on sodium channels. It even enhances the GABA-mediated synaptic inhibition. GABA is an inhibitory neurotransmitter, so it can also act on the GABA. So the commonly used anticonvulsants are gabapentin and pregabalin, and they are very good in neuropathic pain, but it has side effects like somnolence, dizziness, ataxia, fatigue, edema, weight gain. So this has to be explained to the patient that you may feel giddy, you may feel more sleepy, but you will get used to it. If you explain to them, they'll be able to handle it better. Now, gabapentin, the oral bioavailability is unpredictable as compared to pregabalin. So you may need a couple of titrations to reach the effective dose. But the advantage is it is less expensive. Whereas pregabalin, in just 2 to 3 steps, you can reach the desired level, effective dose range, but it is more expensive as compared to that. Topical gabapentin is also available. And they include, and also topical capsaicin is available, can be used for neuropathy. The other first line drug, like anticonvulsants, that we are using to treat neuropathic pain are the antidepressants. So the effect of these antidepressants in lower doses are very good for pain management, particularly neuropathy. In the higher doses, it is more as an antidepressant. Its onset can take up to 1 week, and it is particularly useful in cancer patients because they also suffer from depression, anxiety, and insomnia. How do they act? I said that all the drugs act by inhibiting the reuptake of norepinephrine and serotonin at the dorsal spinal cord synapses. So it activates the descending inhibitory pathway. What are the antidepressants in clinical use? One, we have the TCA, tricyclic antidepressants, which include amitriptyline, nortriptyline. The SSRI, that is a selective serotonin receptor inhibitor. They include escitalopram, citalopram, paroxetine, fluoxetine, and sertraline. Then we have the SNRI, that is selective serotonin norepinephrine receptor inhibitor. They include duloxetine, venlafaxine, and now we have a newer one called the mirtazapine. Okay? And you can also use atypical antipsychotics like quetiapine, risperidone, and olanzapine to treat neuropathy. The ones that are commonly used in cancer pain are the tricyclic antidepressants. They are the tertiary amines like amitriptyline and the secondary amines like nortriptyline. Amitriptyline is more analgesic effect than nortriptyline, but the side effects are more as compared to nortriptyline. Now we have the SNRI, which includes duloxetine and venlafaxine, and we have the SSRI, which includes escitalopram, citalopram, paroxetine. But SSRI have less analgesic effects, more of anti-anxiety. To look at the analgesic effect, then the TCA is more potent as compared to SNRI as compared to SSRI. And if you look at the side effects, the TCA has more side effects as compared to the SNRI and the SSRI. So what are the contraindications of TCA? One is if you have a dry mouth, because it has antimuscarinic effects, it can produce dry mouth. In glaucoma, in cardiotoxicity, in tachycardias, urinary retention, constipation, orthostatic hypotension, you can avoid TCAs. And the side effects are same: somnolence, drowsiness, mental clouding, etc. So the contraindications: avoid when there are cardiac conduction defects or arrhythmias, in prostatic enlargement, and in glaucoma. With SNRI, the side effects are almost similar, but the contraindications, you should be careful in hepatic and renal insufficiency. What are the doses of drugs used in neuropathic pain? When you're using amitriptyline, you always start off with a smaller dose of 10 mg, and over 3 to 5 days, you can increase it to 25, and then you can go up to 50 also. Similarly, with duloxetine, you start with a dose of 20 to 30, and you can go up to 60 mg. Venlafaxine, 37.5, and then step up. With gabapentin, depending upon the age of the patient and the body weight of the patient, you can start with 100 mg or 300 mg. With pregabalin, you can even start with 50 mg also. 50 mg, 75 mg, and you can go up higher. All the dose adjustment should be made in medically ill patients and patients with renal dysfunction. Now, duloxetine has been found to be effective in chemotherapy-induced neuropathy. Okay. And it has been updated, it is there in the updated 2020 guidelines for the initial treatment of peripheral neuropathy. The other drugs in neuropathic pain include ketamine. Ketamine acts on the NMDA receptor, which is present in the dorsal horn of the thing. It blocks the NMDA receptor. It has got side effects like dysphoria, hallucinations, and so you can prevent it by adding a clonazepam or a midazolam to the. Can be given in a number of routes: IV, IM, subcutaneous, oral, sublingual, etc. And just remember that ketamine in sub-anesthetic doses is analgesic. In higher doses, it's more of an anesthetic. So you can give oral ketamine in a dose of 10 to 25 mg TDS. You can also give subcutaneous or IV infusion. Difficult pain, you can use what is called a burst ketamine. And this will be covered in the difficult pain session. Local anesthetics like lignocaine is also useful for treating neuropathic pain, particularly severe intractable crescendo kind of neuropathy. It can be given as an IV local anesthetic infusion. You calculate the body weight, and 5 mg per kg, you add it in 500 ml of saline, give it over 1 hour with cardiac monitoring in a daycare setting. Topical local anesthetics, 5% lignocaine patches are available, and you can apply up to 3 patches. But just remember, if you apply it for 12 hours, you must remove it for the next 12 hours, otherwise toxicity can occur. Other drugs to treat topical drugs are the topical capsaicin and topical gabapentin. So if you look at the neuropathic pain ladder, you have the first line treatment, which is amitriptyline, pregabalin and gabapentin, duloxetine and lidocaine patch. The second line are the opioids, particularly methadone and tramadol. And third line are baclofen, capsaicin, ketamine. The corticosteroids is a multi-purpose adjuvant. It can be given for a number of pain conditions in cancer, like neuropathic pain, bone pain, headache because of intracranial metastasis, for hollow organ obstruction, and also for spinal metastasis. Out of these, dexamethasone is the one that is commonly used because it is a very potent anti-inflammatory agent. It is 25 to 50 times more potent as compared to hydrocortisone. And so it can be given as a single day dose because its duration of action is 36 to 56 hours. So just one dose per day is also sufficient. But just remember, can cause insomnia, so it has to be given in the morning. So particularly in those with less life expectancy, it can provide short-term relief. This is a dose of dexamethasone in various types of. Then we have the GABA receptor agonist. Now, GABA is an inhibitory neurotransmitter. So you have GABA A and GABA B agonists. GABA A agonists are the benzodiazepines. Out of these, clonazepam is the one that is useful for neuropathy. And GABA B is baclofen. That is also good for neuropathy. Now, clonazepam is useful in palliative care, not only for neuropathic pain, but also for terminal sedation. Baclofen, again, useful in neuropathic pain, and it is can start with a dose of 5 milligram PD, and you will keep going up to 20 mg TDs. Bone pain, it can be very agonizing. It could be because of skeletal-related events like fractures or metastasis. It affects the quality of life. So the various agents, the adjuvants that are given for bone pain are corticosteroids and non-steroidal anti-inflammatory drugs, calcitonin, bisphosphonates and denosumab, and palliative radiation. Now, bisphosphonates, the one that is commonly used is zoledronic acid. It blocks the osteoclastic activity and promotes bone resorption. So you're given a dose of IV 4 ml in 100 ml of normal saline over 15 minutes and give it every 3 to 4 weeks for up to 1 year. It has got side effects like pyrexia, renal dysfunction, and osteonecrosis of the jaw, which is a very serious. So appropriate dose reduction is done for patients with renal dysfunction based on the creatinine. Denosumab is more expensive, can be given subcutaneously, less risk of renal toxicity, and it is superior as compared to zoledronic acid for preventing and delaying skeletal-related. Palliative radiation can be done for bone mets, and it is maintains. It has got less serious side effects, but sometimes it takes several weeks for the pain relief. In malignant bowel obstruction pain, which can also be very severe, various drugs can be used, starting with steroids, octreotide, and anticholinergic drugs. And sometimes you can give all the three together also. Other adjuvant drugs that we use are the skeletal muscle relaxants like thiocolchidocoside, like Myoril, tizanidine, clozoxazole. Neurolepts are used when there is agitation and delirium or nausea and vomiting. Antibiotics may have to be given if there is a secondary infection. Sedatives may have to be given for insomnia, anxiolytics for anxiety and depression, and sometimes for constipation, laxity. So these are all the other adjuvant drugs that get used. So how do these drugs act at various parts of the pain pathway? For example, non-steroidal anti-inflammatory drugs are acting to prevent the peripheral sensitization at this level, right? Muscle relaxants are acting at the neuromuscular junction. Nociceptives are again acting at the peripheral nerve ending level. And these anticonvulsants and antidepressants are acting on the dorsal horn of the spinal cord. And drugs like TCA, SNRI, and some of the weak opioids like tramadol are all acting on the descending inhibitory path. That is how all these drugs are acting at different parts of the pain path. Now, coming back to our case scenario, I mentioned about this patient. So, how do we treat it? Okay. Now, if you look at the intensity of pain, it was mild to moderate. It was 4 in the daytime and 6 at night. If you look at the type of pain, he had a combination. He had a nociceptive pain in the shoulder, but in the arm, he had a kind of a neuropathic pain. The pain was worse at night, so there was a temporal nature of it. And if you unveil the meaning of pain, he had functional, emotional, social, and financial concerns. He was unable to sleep. Okay. So, how do we treat it? So, we can use the WHO step 1 drugs to start with. We can give a combination of paracetamol with NSAIDs. But because the pain was more at night, we could give a higher dose of the analgesic. Like paracetamol, you can give up to 1 gram, or diclofenac SR 100 mg we can give in the night, so that the pain will be sustained during the night. Now, because of the neuropathic pain, we can add an anticonvulsant or an antidepressant. Because he had sleep issues, we can add a sedative. Just remember, when the good sleep happens, it decreases the threshold of pain, so the pain also can come down. And of course, the most important is a psychosocial support for his financial and social concerns. So that is how we do a total pain management of this patient. So to summarize, the WHO analgesic ladder is a sheet anchor of cancer pain management, which is valid even today. Can be used for other kinds of pain also. It's very simple, easy to implement, can be implemented worldwide, and importantly, it has legitimized the use of opioids in cancer and non-cancer. Thank you for your patience.
Thank you very much, madam. Such a detailed, stepwise, where it is happening, why it is happening, and how to manage. So you've given such a detailed explanation. So things should be so easy, and especially the diagrams which have all the where they act, the chemical mediators, all the descending inhibitory pathway. Exactly, that's what it's a combined approach is needed, and once they know what is causing the pain and how to manage. So big thank you, and hope anyone has, you can unmute and ask. So that could be a one option. Or if you want to type in the chat box also, at present I've checked, there's nothing there. So if anybody, I explain NNT once more. Madam, you're happy to take, or they've just asked you. Explain NNT once again, madam.
Okay. NNT is called the numbers needed to treat. That means for if you're treating, giving paracetamol to 5 patients and only 1 gets relief, the NNT is 5. Whereas if you're giving a particular drug, out of 2 patients, 1 gets relief, that means it's a more potent drug. So drugs like brufen and diclofenac, the NNT is only 2. That means for every 2 patients, 1 is getting relief. In paracetamol, relief happens only 1 in 5 patients. So paracetamol is less potent as compared to diclofenac or brufen. So that is how they calculate the NNT.
And somebody else had asked about breakthrough pain. That is a pain which comes, see, they take some medications, and in between, in spite of being on the dose which is like 4th hourly, they may have pain. And the cause could be an additional factor. They might do something different, or they may have some other thing happening within them due to the disease per se. The pain which is happening in between or additional to, they have pain and then additional to what type of pain they have. Incidental pain, breakthrough pain, all that are synonyms. Madam, you can add on. I've just
see, any pain that is happening even before the duration of action of the drug is over is called pain. Like, for example, you're giving morphine. effect of action is 4 hours. So normally up to 4 hours, they will have good pain. But people who the dose is not sufficient, that particular dose, they will get pain even before 4 hours. So that is breakthrough pain. So we have to treat the breakthrough pain. So there is a way of treating it also. How much of morphine you have to give. And then you have to recalculate the whole dose. So that is called breakthrough pain. In the session on difficult pain,
Yes,
it will be dealt
and
with in more detail.
exactly. And also when you have morphine session also, when you are doing
Yes, then
morphine
also it will be covered in the
and
morphine.
when you are giving morphine prescriptions, they will tell you have to give regular prescription and also give prescription for rescue dose, breakthrough pain, all that is, it will be, it's like, as madam said, the dose and thing, how much you give will be covered there. But what, the basic thing to understand is that, as we explained, what is breakthrough pain. And there are a few more questions. In cancer patients, post-operative, will you suggest adding anticonvulsants? See, these are all individual. Madam, you go ahead, madam.
What is it? What's the question?
In cancer patients, post-operatively, will you suggest adding anticonvulsants?
Post-operatively? You know what? Nowadays, before operation, people are giving anticonvulsants.
Yes.
Gabapentin is being given as a pre-operative drug. Forget cancer, even in the normal operations they're giving.
Yes, yes. For knee replacement and all, I have used.
Yes. So it has a role even in the pre-operative treatment. Definitely, even it can be continued in the post-operative period for few days.
See, whoever had asked, no, these are all individual. See, the comfort in usage. There's something called as preemptive analgesia. So that is how we use it pre-op. So for all that, no, either the whole team should be happy, and then it is being used as we have used gabapentin a lot. Many studies, many papers you'll be able to find out, and there is role for it. Pre, post. Main thing, if the whole episode is managed very well, then the incidence of chronic pain itself is said to be less. Next question, ma'am. If there's no relief on step 1, we increase dose to full dose before shifting to step 2, or shift to step 2?
We have to give the full dose.
Exactly.
We have to give the full dose before we can move on to step 2. So that's for sure. The second one is paracetamol 1 gram is available. It should. See, I said that paracetamol can be given up to 3 to maximum 4 grams a day if the patient has no liver dysfunction. Okay. So that means you can give it. It is even 3 times a day you can give it without a problem.
6 hourly. Normally, like 15 milligrams per kilogram body weight, 4 to 6 hourly. That is the dose prescription.
But if you're giving 1 gram, then you may have to give it 8 hourly.
Okay. So see, and also as madam is telling, no, the physique of the patient. If the patient is a 40 kilogram patient, you have to see everything. That's why attention.
Then we have to calculate according to the body weight, 12 to 15 milligram per kg body.
That's why I said. So these
do not exceed 90 milligram per kg body. That's it.
So that's what these all depend on individual that patients build, other factors, everything. So the dose is 12 to 15 milligram per kilogram body weight each time. Maximum is 4 grams for healthy normal, 3 grams for if you suspect something is abnormal, like liver, something like that. So like that, there are a few things because it's generally very safe. But if there is hepatotoxicity, you have to come down. Then another thing is that tapentadol, does tapentadol have a risk of
serotonin storm? So as far as I know, if you stick to the normal dose, I don't think you may go in for serotonin storm.
Exactly. So this query, comes up even when tramadol is combined with TC, like tricyclics. But generally, as I said, in this 15, 20 years of chronic pain practice, if everything dose is kept within the prescribed, very rare, okay? For example, whatever you're using, you should stick to the, not go beyond. So, and whenever you're using, keep a close eye and see. Generally, it doesn't happen. By books, it is there. So, you have to be aware. And then, if someone is generally a known epileptic, having convulsions still, those patients are not, you should be a bit cautious. Then, all cancer patients are prothrombotic. So,
they are talking about the selective and non-steroidal antibiotics.
should be.
See,
And
all
then,
patients are prothrombotic, but the indications they are talking about is cardiac and neurological. Okay. History of TIA, history of angina, those patients you have to be very cautious.
exactly, some
And
known
even
cardiac
pregnancy is a prothrombotic
Correct,
condition.
correct,
So
correct.
many things, you can't generalize it.
No, that's what. See,
The
again,
other
with,
thing is, yeah,
with those things, no, individual patient specific. And then what duration steroids can be given?
see, normally
So what do
steroids are
we,
given only for 3 to 5 days, not longer than that.
and when you give it for 3 to 5 days, no big increase, decrease, tapering, all that.
And
no.
then though tapering is also not required when you
If it is 3 to 5 days, not required. Whatever do, see, especially in palliative care, if you're going to use it for that particular symptom management. For example, for someone having severe dysphagia also, it works wonders. So for 3 days, 5 days only, and then it's given as one dose in the morning itself. So
exactly.
that's circadian rhythm.
That's the advantage of dexamethasone, one dose a day in the morning.
Okay.
But always give it with the proton pump inhibitor. Very important. Steroid should be given with the proton.
Exact must. Gut protection is always must. Then one more question: what maximum NNT of a drug to be used as analgesic? But if there's nothing, oh, madam, anything you would like to say?
What can be the maximum NNT of a drug? See, I don't understand your question, but non-steroidal anti-inflammatory drugs is among the most potent analgesic. I don't know what is for morphine. I'm not sure of the NNT, but for these drugs, Brufen has got 2, which is supposed to be very potent. Diclofenac has 2.
So it is for us to know that number needed to treat. If you see somewhere the number needed to treat, for example, if it is low, it is potent. If it is high, it is less potent. And then
this question, what about the combination of gabapentin and morphine? That's very important. That's a good question. See, you can give anticonvulsants. If the patient is not responding to anticonvulsants, add an antidepressant. The combination works beautifully. Okay. Particularly when there is of tingling, numbness, and very much signs of neuropathic pain, you can add an antidepressant. It has a cumulative effect when you add both together. Only if the combination is not working do you move to other anti-neuropathic agents. So first you try either anticonvulsants or antidepressants, then you combine the two, okay, and then see.
Exactly. See, they have the impact and effect slowly. So patience is of great importance here.
Patience is very important, very important.
And you have to
when I start this nortriptyline, I tell them for 1 week, don't expect any changes. It will take 1 week for anything to happen. Don't think that after 2 days I'm not getting effect. Even for gabapentin, I tell the same thing. Please wait for a week before you say that it's not working.
That's also generally we say wait for a week for it. First week take religiously without any effect. Then 2 weeks for it to start working. 2 months to say that it is not working. These are general rules. I think all of us will sing the same song. Yes. So maybe we can go ahead with the case presentation and have the rest of the discussion also along with that. And if anybody wants to ask or anything in the meanwhile, think about your queries and questions, and then we can cover. Over to you, Gayatri.
Am I audible?
Yes.
Okay, we have a case presentation today. The case will be presented by Dr. Tarun, and I am sharing the screen for the same. Dr. Tarun? Screen is visible?
Yes, ma'am. Yes, ma'am. Good evening, ma'am. Good evening, everyone.
Good evening.
Ma'am, I am audible.
Yes, yes. You can start.
Okay. Ma'am, I'm presenting case of 78-year female patient with a diagnosis of carcinoma right breast with suspected metastasis. Presenting complaints of patient are pain in right breast since 1 month, pain in back region since 1 month. History of illness. 78-year-old female with the right breast mass found to be carcinoma 4 to 5 months ago, for which she underwent a modified radical mastectomy 4 months ago and started on chemotherapy. Currently, she has completed 5 chemotherapy cycles, but now complaining of pain in right breast since 1 month, which is sudden in onset, severe in intensity, sharp in nature, and lasting for 1 to 2 minutes, and then itself get relieved. Pain is radiating to back and right axilla. Pain is aggravated on lying down and relieved on standing. There is tenderness present. She is also complaining of backache since 1 month, which is severe in nature, sudden in onset, sharp in nature. There is no radiation. Pain is aggravated on lying down and relieving on standing. On examination, general physical examination. Pallor is absent, icterus is absent, cyanosis is absent, clubbing absent. There is no lymphadenopathy, pedal edema absent. Normal bowel and bladder habit. Her sleep is disturbed due to severe pain. She is malnourished. In right breast region, there is erythema and tenderness. Other systemic examination is normal. Treatment and significant investigation. Routine investigations done are complete hemogram, RFT, LFT, serum electrolyte, RBS, lipid profile, ECG, chest X-ray, X-ray LS spine, PET scan, and MRI scan. Treatment. She is currently on chemotherapy. For pain, she is currently on tablet paracetamol, tramadol twice a day, and tablet pregabalin 75 milligram twice a day. Psychosocial aspect. 78-year-old lady who is widow and lives with her son, daughter-in-law, and grandkids. Her son is retired from army as major, and also her husband was subedar in army, and her family is financially sound. But she is worried about her disease and its spread. Main concern are metastasis, pain, and disease reoccurrence. Summary: 78-year-old female with post MRM for carcinoma right breast, currently on chemotherapy with severe pain in right breast region and back region with probable metastasis to ribs and vertebrae. Discussion points: what to be done for pain management, how to support her psychologically, and what can be done for sleep. Thank you, ma'am.
Thank you, Dr. Tarun. Good that, see, bringing up these cases, gives us an opportunity to discuss and move forward. You prepared this case, but now after attending Madam's session, what is that you think? So if you don't mind, no? So anyhow, this session, your output and information before session, after session, will have some change. So from your point of view, if we ask, whatever you said, no, your discussion points, what do you think? Like what to be done? You just give an idea and then we go for the discussion. Madam, will that be okay?
Yes, perfectly okay.
So why, if you don't mind, what would you think? What to be done for pain management? How to support her? And what can you go ahead?
Yes,
don't have hesitation. Okay, this
yes,
is not. This is the platform for you to give your opinion, get discussion, and modify management plan for your future patients also. Okay, go ahead.
Yes, ma'am. Ma'am, according to treatment, ma'am, currently she's on paracetamol and tramadol and pregabalin. Ma'am, currently she's on step 2 WHO ladder. So I think, ma'am, we can increase the dose of pregabalin.
Her her pain score before and after treating, what difference was there, and do you remember, or did you check, or if not, what is that you would think?
Ma'am, I don't, ma'am, remember that. Sorry.
Okay, so or was it mild? Like you can.
Ma'am, it severe, ma'am. It was severe. She's already taking paracetamol, tramadol, BD, and pregabalin 75 mg BD. After taking all these, she's having severe pain.
Then what do
Yes,
you
ma'am.
think?
Ma'am, she's currently on step 2 WHO ladder. Currently taking, ma'am, we can increase the dose, like paracetamol, tramadol. We can increase that dose, and we can also increase the pregabalin dose. Currently, she's on 75 mg BD. We can increase up to 300 mg. And same with pregabalin, ma'am. Same with paracetamol and tramadol, ma'am.
No, that's it. You do step by step. You increase the paracetamol, tramadol, and with the pregabalin, with your age, everything, no? So 75 means you can make it 75 BD, not up to, yes, you have
Yes,
room.
ma'am.
Just because you have room in every drug, you just don't go to the maximum. You have to titrate it slowly and review the patient regularly, and there is room for increasing the doses, and then observing her and seeing whether she's coping, and then also is she getting pain relief, or is she getting any side effects, everything, because her age, everything you have to keep in mind.
Yes.
And then we'll get your opinion, and then we'll discuss also other things. Or shall we go one point at a time, madam? What would you think?
We can just go one at a time.
Yes, 1 point.
Like, how much of paracetamol are you giving?
Correct.
Arun?
Go ahead.
How much of paracetamol are you giving?
He's currently 500 plus, ma'am. She's on 50. 500.
500 mg?
Yes, ma'am.
How many times?
Currently, BD, ma'am, BD. 2 times.
Now, based on my talk, would you like to make some changes in that?
Yes, ma'am. Yes, ma'am.
Yes.
It can be made to 650 mg 6 hourly, ma'am.
Every 6 hours. Okay.
Yes.
So
yes,
first of all, you should make sure that she's getting, like someone asked a question, do we increase the dose to the full dose before we move up to the next step? Okay.
Yes,
so you have to give a full dose. Her body weight is how much? What's the weight? Weight of the patient?
It's around 45 kg, ma'am. 45.
So 45 kg. Now you have to be careful. When she's 45 kg, make sure that she's not getting more than 15 mg per kg. Does she have any comorbidities like liver function, dysfunction, or any other cardiac issues? No?
No, ma'am. No.
The other thing is, would you say she has a neuropathic pain?
Yes, ma'am.
Why do you say that it's a neuropathic pain?
Then she's also radiation, ma'am. She is complaining of radiation to the axilla and to the back.
So radiation doesn't necessarily mean neuropathic pain.
Yes.
Neuropathic pain is characterized by burning, tingling, current-like, numbness. All those are the features of neuropathic pain. So there's no point in increasing pregabalin to 300. That is too much for her. I would not go more than 75 mg BD for her, right? Maximum. So what you need to do is, it is more of a nociceptive pain with probably bone pain. Okay. So you have to treat it like that. So you go paracetamol, you go up to the maximum dose you can, and then you can add a non-steroidal anti-inflammatory drug before going on to tramadol. Like you can add either ibuprofen or diclofenac or something like that. And then maybe we have to find out if there are metastases, whether she needs something for a bone mets. Okay, anti-inflammatory drugs are good for bone mets. Like someone said, you can add a steroid. But first of all, you have to find out if she has bone mets by doing her MRI spine or her PET CT or something like that has to be done. Okay. But without thinking there's a neuropathic pain, there's no point in stepping up your pregabalin. Even if you give 75 mg once a day also, it's enough for her. Once or maximum twice. But you have to first identify whether it's a nociceptive pain or a neuropathic pain, or are there any other kinds of pain like bone pain or anything like that. Okay.
Yes, ma'am.
So that the analysis is very important before you start your treatment. And you have to take the NRS, very important. Is it 7 out of 10, 8 out of 10? And after treatment, has it come to 4 out of 10, 5 out of 10? That has to be noted down.
Yes.
Like the first session, the assessment is so important. Assessment has so much of benefit. It's not only for diagnosis, for treatment, outcome, for everything. See, that's what. See, take it in a nice way. If you diagnose and assess and diagnose properly, it is going to help you in your management. So, okay, I to start off, I had 8/10. With this medication, she came down to 6/10. She stayed in 6/10, 4/10, 2/10. Suddenly, some change from 2/10 goes to 8/10. So everything counts there. And
The
see,
progression of the disease itself can increase.
Exactly. So when it is 2/10 for 4 weeks, suddenly some. Then back to the checkboard, we say, what is that? What is that I missed? Is there any change? Then she might say, no, I was totally fine. Suddenly I developed big loss of weight, loss of appetite. I was eating, and after this morphine, I was doing everything I was eating. I, in fact, liked food also. Suddenly, see, after 4 weeks, I don't know why. So all of a sudden, I literally don't want to eat. There's no taste. I don't have this, and I'm feeling so weak. Then something is wrong. So that assessment, assess, reassess. So that will help you in a long way. As Madam said, it could be disease progression, or something may be missing, or she may be, I became better, so I am not taking my medicine. Very common. We are all human beings. We have a patient who everything will be paka. Then suddenly you ask him, no, 4 days I didn't take medicine. 5th day he will be.
You have to see whether they are following, compliant with the prescription also. Very important.
So these are
and then if they can afford, they should get the MRI done or the PET-CT done to know whether there are spread also happening. No, instead of vaguely treating, you can't treat bone mets unless you prove there is bone mets, right?
Yes.
So that's it. Sometimes, it is very important that that how you like this pattern things. They are very helpful. But affordability, everything is there. That's why we have to tell them many times outside it may not show. Okay, we all know about these malignancies. Okay, microscopic spread. Can that be seen? What's happening inside many times we don't even know. So regular follow-up and those things. Any suspicion? And then again, every time what you have to be sometimes realistic also. If the patient can afford and do, fine. Otherwise, what are the other options? Then you have other ways of managing also, palliative chemo, palliative radio. So many options are there. Okay, so like that, every aspect has to be considered, dose and things. There were some things, skeletal pain, that's what we have already discussed. Anxiolytic also we said, always this tricyclics and anti-epileptics separately together, that also works very well. What about thrombophlebitis pain in the arm? Burning. Is that like
see, there is a condition called post-mastectomy pain syndrome. So that also needs to be ruled out. So we can check it out by knowing whether that's a good thing. It could be thrombophlebitis also. It could be a nerve injury also. So that is why we have to know whether there is a neuropathic element to the pain by asking a detailed history. It's a pain burning in nature. You find electric current-like sensations, or is there tingling, numbness? These have to be asked, or in a proactive way. Not, you don't expect the patient to come up with it. You have to ask for it. So post-mastectomy pain syndrome is a condition. Maybe you can read up about it. This could be a post-mastectomy case.
Exactly. See, all possibilities. That's what as I was telling. Whenever thing is there, go back, review, make sure that nothing is missed. Can someone has asked, can we use patches even at step 1? Tricky one.
Can use. You can. New patches available. Diclofenac patches are available. You can try it out, but I feel the bioavailability oral will be better than with the patch. But
Exactly.
if people have difficulty swallowing, you can definitely use patches.
No, like, see, generally, I wanted to ask, Madam, people know, like, I don't know why, so there seems to be a fancy for patches.
Yes, fentanyl patch, if you apply like that.
But
It is so expensive.
Unfortunately, always we are taught think simple, be simple, and you can get the best by being simple also. Don't think that like a general thing, no? Something which is simple can be sound and sufficient. Okay, not that only hi-fi works. Sometimes hi-fi may not work also.
The WHO LAD is such a simple tool.
Exactly.
If applied in a proper way, you can get good relief with the WHO. But you should know how to apply it. That is the main thing.
Exactly. Someone has mentioned audio is low. I didn't feel any difficulty. So
there's no difficulty.
That's what. And so that's what. See, not that who had asked about Dr. Praveen. See, not that you should not use, as Madam has said, no, appropriate. So more than that, no. When you all study and do everything, you yourself will find out something which is, you'll have the further sessions, no, in about morphine in detail. You're going to have one session itself. After that, make a call on your answer, I would say. And then, does buprenorphine come in second or third step? Buprenorphine, Madam, you go ahead, then I will add my opinion.
Buprenorphine comes in the third step. It's an my volume is low.
No, Madam. For me it's okay.
Oh, sorry. Okay.
Because someone had mentioned okay. Low, but it's okay only.
See, buprenorphine, methadone, they all come as a third step of the analgesic ladder, and we will talk about it in the difficult pain session. Exactly. Talk more about it.
Not that it's not used, but it has its own role to play. Okay. So as Madam said, no, as I keep telling every day, you'll all get bored of me. Why have the charm of each session for that day? Because everything, every day should be interesting. In part to each day. So we'll go with it as we get to that, because whatever, no, first get the benefit out of today. So the other 2 points, no, how the other things which were there, like the other what all other psychological support you can give. You have to get the help of the counseling psychologist, and then assessing the patient's mood state, and then what are they aware, what are they not aware, and then first giving something called as realistic assurance. That also, again, you'll have a lot of information about that on communication and psychology sessions. Okay. And then what was the third thing you had?
Reassurance, sleep. For sleep, you can add one of these drugs. You know, one drug like clonazepam, I find it very good because it is also useful for neuropathic pain and also gives a good anxiolysis and sleep. So you can add clonazepam 0.25 mg tablet at night. You can go up to 0.5 also, no problem. But this lady is only 48 kg, I think 0.25.
That's what. So those, and then sometimes your amitriptyline itself might help with sleep.
Yes, again, if you're adding amitriptyline, that's sufficient.
That's what, normally that works. Again, for that, telling them when they should take before 6 or 7, not take at 11 o'clock. If they take it between 6 and 7, their normal sleep pattern will be followed. Unfortunately, the patient takes it at night 10 o'clock and tells next day morning I'm feeling sleepy. If they take it between 6 and 7, morning 6, 7, they'll be bright-headed. So these
That's what I
small
always, whenever I
Mm.
give anticonvulsants or antidepressants, I write down, take it before 7 o'clock. I write it on the prescription.
Yeah, exactly.
Otherwise, we ask him, what time did you take? I took it at 11 o'clock after my dinner. Then how will you feel fresh in the morning? So it's very
So that's what-
important. The time also has to be mentioned.
If they miss 7, I say, please don't take and blame the tablet. I am very point blank on that, because it's the wrong timing, and then don't blame the tablet. Okay, so, and it is our role also there to tell all these things. Unfortunately, many patients tell me, nobody tells like you. And I say, that's how it has to be told. So at least we'll be happy if all of you take up these points and practice, so that the patient gets the benefit. Okay. Anything else? I think we have
Talking therapy, reassurance, all very, very important. Very important. That itself will take half the pain away if you can do that.
That's what. All these are all what to say, basic concepts. Those don't change. 20 years down the line, 200 years down the line too. There are
I think that's enough. I
just
think
anything in the chat box, nothing more. Okay, over to you. Big thank you, madam. I
thank you,
always
Radha.
enjoy your sessions.
You really enliven the session, Radha.
it's man, see, like people like you and all to have, it's a privilege for all of them. Okay, getting from experts to know all these things. So, and then as I said, only for all of you, put this into your practice. First person, you will also be happy, and then your patient will be double happy. That's it. Okay, big thank you, madam. Over to you, guys.
Thank you so much.
Thanks to Dr. Mary ma'am for the wonderful session, and thank you all for joining. We are looking forward to see you on the next session. Bye.